Juvenile idiopathic arthritis is the commonest chronic inflammatory rheumatic condition in children. The criteria to diagnose it is the age of onset less than 16 years, arthritis, duration of it more than or equal to 6 weeks, in absence of infection or any other defined cause. They present with early morning stiffness or stiffness after periods of rest, joint pain and swelling involving both small and large joints, intermittent limp, deterioration of behavior or mood, avoidance of previously enjoyed activities. But it depends on type or it may be indolent. There are 6 subtypes of juvenile idiopathic arthritis: oligo, poly, systemic onset, psoriatic, and enthesitic. We can divide oligoarthritis into two. If the joint involvement is 4 or less than 4 throughout the disease course, we call it as persistent oligoarthritis. But if the joint involvement is more than 4 after first 6 months, we call it as extended oligoarthritis. Chronic anterior uveitis is present in 20% of them. Most commonly affected joint is knee joint, and ANA can be positive or negative. Next is polyarthritis. It means the joint involvement is more than or equal to 5 in first 6 months. There are also two types: rheumatic factor negative and rheumatic factor positive. Positive means it should be positive 2 or more tests done at least within 3 months apart during first 6 months. So this has a poor prognosis and it is similar to adult rheumatoid arthritis, and there may be rheumatoid nodules as well. 5% of those who have rheumatic factor negative polyarthritis can have chronic anterior uveitis. To say it is systemic onset juvenile idiopathic arthritis, there should be arthritis more than 6 weeks and fever more than 38.5 Celsius, which is quotidian pattern, intermittent spike of an evening, and normal in between time at least for 2 weeks, documented to be daily, accompanied by one of the following features: erythematous rash, which is salmon pink in color, macular and non-pleuritic, and generalized lymph node enlargement, hepatomegaly, splenomegaly of both, and serosite. It has a poor prognosis. You can diagnose psoriatic arthritis when arthritis and psoriasis is present, or arthritis and two of following features are present. 20% of these patients are associated with chronic anterior uveitis. Next type is enthesitis related arthritis. You can diagnose it when arthritis and enthesitis are present, or when arthritis or enthesitis plus two of following features. These patients are also occasionally associated with acute uveitis. Early aggressive treatment will improve outcome and prevent complications. As a summary, for all subtypes, first line treatment is NSAIDs like ibuprofen. Then second line for oligoarthritis is intra-articular steroids. If it doesn't work, we can give methotrexate. For polyarthritis, we can use second line drug as methotrexate, and if it doesn't work, we can give biologics. For systemic onset JIA, second line is biologics. With or without having active systemic symptoms may differ the treatment. Let's talk about the complications. Blindness from uveitis, joint contractures and erosions. Chronic inflammation may lead to limitation of joint movements and joint replacement. If this persists for a long time, it may cause bone expansion from overgrowth. Early physiotherapy will prevent joint contractures. Next complication is growth faltering. This may be occurred due to uncontrolled inflammation, which cause early fusion of growth plates in affected limbs, which may result to undergrowth of the limb and cause limb length discrepancies. Chronic inflammation and steroids can cause generalized reduction in linear growth. The most serious complication of systemic onset juvenile idiopathic arthritis, which is a life-threatening condition, is macrophage activation syndrome. There may be associated anemia of chronic disease, delayed puberty, and osteoporosis. We can reduce the osteoporosis risk by introducing dietary supplements of calcium and vitamin D, regular weight-bearing exercises, and minimizing the oral corticosteroids.